My name is Sara Dugan. I'm a psychiatric pharmacist and faculty at Neomed.
Oh, perfect.
Um, Hold on, that's the wrong one. Here we go. I will be presenting our didactic today. So we did have a change of plans from what the original schedule was if you looked at it at the beginning of the month. So we are swapping in for today with a journal club. So we came across a few different articles, but this was the one that the hub team said might be most relevant to all of the folks that join us here in the morning. So we're just going to walk through what this article is. It was looking at two different things. It does look at changes between formulation, but it's also starting to look at individuals who are using fentanyl versus those who have not been using some of the other synthetic opioids. So we will just walk through why did they do it, what did they do, and what did they find. The article is posted for you. Thank you to Kara for getting that up there if you want to see it along with the slides. So this was interesting because it actually is a post hoc analysis of a phase 3 clinical trial. So it wasn't necessarily something that was developed independently to be looked at. It was something that was evaluated kind of after the fact. They were really interested in looking at the role of fentanyl. So synthetic opioids, including fentanyl, have been a driver of overdose deaths. They've seen a pretty steep increase over the course of the last 5 to 7 years. One of the biggest spikes happened between 2020 and 2021 with an increase in over 38%, with the vast majority of those being attributed to contributions from synthetic opioids, including fentanyl. Some of the reasons behind why this is such a concern is because the fatalities with exposure have been pretty significant. It's possible to have a fatal overdose with as little as 2 milligrams of fentanyl. This was actually a picture that was taken from the DEA page where they were looking at pure synthetic opioids, and they were finding very small amounts that were able to create pretty significant symptoms, especially if individuals were accidentally coming into contact with them, even through the skin, which was a little bit different than what they had seen in the past. So because of the risk of the increased fatalities, there's obviously interest in looking at that, but there's been some discussion that maybe there are different cohorts. Individuals who have opioid use disorder, those that may be using other opioids may have a little bit of a different feel than what they see with some of the folks that are using synthetic opioids. The rapid distribution, the significant lipophilicity, we get pretty immediate effects. And they, again, can be relatively robust, and that tolerance does tend to be incredibly problematic. So the question that the authors were looking at was, okay, so we have different formulations. Do sublingual and the extended release subcutaneous injection both work equally well for our opioid use disorder patients? And can they work for all of the different cohorts of opioid use disorder patients that we see, including those that are using synthetic opioids like fentanyl, because if they can make a difference there, it may be one of the interventions that can help lower those overdose deaths. So that's where they were coming from. And they decided that they were going to take the information that they had from that phase 3 clinical trial to evaluate two different things. So the first thing they wanted to see was if buprenorphine is effective in treating opioid use disorders in individuals who are using. They were focused on fentanyl. There were other synthetic opioids that could be identified, but this was the main one that they were looking at. And they had set that up ahead of time when they were doing the testing in the phase 3 trial, so they actually were able to use the existing data. They also wanted to know if there was a difference. So the phase 3 clinical trial was for the extended release subcutaneous injection of buprenorphine, the Brixadi, that's weekly and monthly injections, and they wanted to see if there was a difference between the sublingual and that subcutaneous injection. So it really was a twofold question. So as I had mentioned, this was taking the data from that phase 3 study and reevaluating it. So the phase 3 study itself was a randomized, double-blind, double-dummy, active control multi-center trial. It was set up for 2 different groups. So the first group was given sublingual buprenorphine naloxone. They were able to increase the dose up to a maximum of 24 milligrams daily. And then they were given placebo injections during phase 1 every week. And then phase 2, they got placebo injections once monthly. The second group was given a sublingual placebo tablet, and then they had active subcutaneous injections weekly that moved to active subcutaneous injections monthly. So the patients were initially enrolled in a 3-week screening phase. So they were looking at what their symptoms looked like, if they met criteria for the clinical trial. Then they were randomized into the groups, and starting with phase 1, the 2 groups started with whatever their active treatment was. So they had to show up on the first day of phase 1 in active opioid withdrawal, and they were followed for 12 weeks in phase 1. They then transitioned to phase 2. During phase 1, they had weekly appointments. During those weekly appointments, they had urine drug screens. They completed questionnaires about self-reported illicit substance use. They completed a few different withdrawal scales to collect the information. During phase 2, it was more on the maintenance side. So starting at week 13 and followed for the rest of the 12 weeks in phase 2, those injections were moved from weekly to monthly, and the appointments were monthly. So they weren't seen every week, they were only seen once a month, but they included 3 random visits. So yes, they had to be seen once a month, week 16, week 20, week 24, but there were 3 random visits that were thrown in there. Follow-up, all of the individuals in both groups were then transitioned over to sublingual buprenorphine naloxone for the follow-up, and they were just kind of seeing if there were any changes after the patients stopped some of those subcutaneous injections. So watching both first relapse, symptom recurrence, or any type of adverse effects from transitioning off the injection. Outcome-wise, this was set up really looking at what's the efficacy and safety of the subcutaneous buprenorphine injection. So the urine drug screen, as I mentioned, they specifically had a whole panel that was trying to capture fentanyl, some active metabolites of synthetic opioids, and a number of expanded opioids. So they really were looking, cocaine was in there. They were trying to make sure that they captured any type of illicit substances with that urine drug screen. The self-reported illicit drug use, and then they had the 2 opioid withdrawal scales, so the clinical opiate withdrawal scale and the subjective one. They used the visual analog scale for cravings, so the 0 to 100, and where did their cravings fall, and then just general adverse effects that were reported. Because this was post hoc, so they had finished phase 3 and decided to go back and look, and they wanted to look at the data because they could evaluate what was happening with that cohort who had been using fentanyl at baseline. And they could split it then by formulation of buprenorphine to see if there was a difference between them. So the phase 3 trial itself was the intention to treat, and they used a comparative effective analysis to look at both of those groups. So was there a difference between those who had fentanyl present at baseline and those who did not in the patients who were on buprenorphine? And then was there a difference between the 2 formulations of buprenorphine? They did something interesting. So they used, they took the percentage of patients who had negative urine drug screens They then divided that by 18, because that was the total number of urine drug screens that they had, and multiplied that by 100. So they essentially turned it more into a continuous score that went from 0 to 100. So 100% would mean that the individual had all negative urine drug screens the entire time. So they really adopted what that value was, and they used this to try to evaluate how well patients were responding and if they were using other illicit substances. So they analyzed that data using the analysis of variance, and then they did do the mixed model repeated measures just because they were doing all of the rating scales weekly for those first 12 weeks and then monthly for the next 12 weeks. So they were looking at a whole bunch of things. Their inclusion criteria, so they included patients that were 18 to 65 years old. They had to have moderate to severe opioid use disorder. They could not have used other pharmacologic treatments for opioid use disorder in the 60 days before screening. So they kind of wanted to make sure that patients did not have carryover from anything else they had been using. They also were excluded if they had a substance use disorder that was for a different substance other than opioids as their primary, and if they had the presence of another opioid use disorder that was pretty competitive with the opioids. The exceptions were for caffeine or nicotine. And then for patients who required chronic pain management with the opioids, they also were excluded. So what did they find? So they differentiated between the two cohorts. The individuals who had fentanyl present at baseline, there were 123 of the participants. So 64 of them were in the subcutaneous injection group. 59 of them were in the sublingual group. Their average age was 39 years old. 61% were male, 76% were white, 21% were Black. For those that, did not have fentanyl present at baseline, there were 305 of those participants. So 149 in the injection group, 156 in the sublingual group. Average age, again, was 38. 61% were male. From an ethnicity, it was 73% white, 24% Black. Their withdrawal scores, their craving scores, all were equal at baseline. So they did appear to all have very similar symptoms when they first started phase 1. So what did they find? So they were looking at the negative urine screens. So that percentage that they were looking at, how many of their urine drug tests came back as negative so that they weren't using other illicit substances. The blue bar is going to be for those who are fentanyl positive. The red bar is for those who at baseline were fentanyl negative, so not considered to be using fentanyl illicitly. They found that individuals who were not using fentanyl at baseline statistically had more negative urine drug tests than those who did have fentanyl present at baseline. To be fair, despite the fact that we were at the end, it was still about 35%. So we had a pretty significant cohort that still had some positive urine drug tests, but the difference between the two did suggest that those that had been using the fentanyl at baseline may have a little bit more of a struggle getting them into treatment and truly into recovery just with what our traditional methods are. So they look like they maybe were having a little bit more difficulty during that time. When they looked at the difference between individuals who were using the sublingual buprenorphine naloxone and those that were using the injection, that difference between the cohorts stayed with both groups. It was less pronounced with the subcutaneous injection group. So as you can see, the percent of patients who had negative drug screens who got the subcutaneous injection was 28%. So that was more than what they saw with the sublingual group. And then you see greater numbers, but still we're under 40% for all of them. So there was a difference between the sublingual and the subcutaneous injection. The subcutaneous injection group had statistically more patients that had negative urine drug screens than those that were in the sublingual group. When they looked at some of those other outcomes, they didn't provide us much information related to the cravings, although the cravings did appear to be reduced across the board, but they didn't see any difference between the COW score, the subjective opioid withdrawal score, or the adverse effects between the groups. So it appeared that all of them had pretty rapid improvement in all of their symptoms, and it was maintained throughout the entire duration of the study. So they did see a pretty significant improvement across the board. This was just one of the other visuals that they had. So for the group that did test positive for fentanyl, at the bottom, the number of urine samples that were negative, you can see that there was that distribution, and it was slightly different between those two groups. So the blue bar being those individuals who are on the injection, and the yellow one being those who had gotten the sublingual buprenorphine naloxone. So yes, a difference in the negatives, but we didn't see much difference in terms of those withdrawal symptoms or adverse effects. So what does that mean? So what? Well, more than 20% across the board of patients were consistently having negative urine drug screens. Their withdrawal symptoms had gone down to relatively low numbers where they were having minimal symptoms that were impairing their ability to function. There was a difference between the two groups. So those who had fentanyl present at baseline were not achieving as many negative urine drug tests as those who did not have fentanyl at baseline. And there was a difference between the formulations. So they did see more of those negative urine drug results with the subcutaneous injection. So they found a difference between each of those cohorts. To be fair, from the clinical significant standpoint, though, again, just to keep in mind, we were less than 40% across the board. So likely the intervention of just the pharmacotherapy alone is not going to be enough to move the majority of patients into recovery, but it definitely was an improvement for at least a solid quarter to a third of those participants. Oh, I had not put in here. So there were not many adverse effects that were reported. There was less than 15% of participants did have adverse effects. The most common, so those that were between 5 and 10%, were nausea, constipation, elevations in liver function tests, both AST and ALT. They saw increases in upper respiratory infection as well as urinary tract infections, although this was not necessarily thought to be related to the study medications. Then it may have just been a result of the fact that they were having this. Some of the participants were recruited during the winter months when they may have gotten sick. And then injection site reactions. So that was the main differentiator between the two groups. Obviously, there were placebo injections, but there were more injection site reactions and injection site inflammation in the patients who were in group 2 who got the active buprenorphine injection. Overall completion, they had about 60%. So 61% in the sublingual group and 56% in the subcutaneous injection group completed the trial. So they did have a pretty significant number that were able to stay with them all the way through all of the phases. So just kind of thinking about how helpful is this information, especially recognizing they went back to take a peek at it. It's one of the few clinical trials that had specific data to be able to evaluate consistently whether or not there was a presence of fentanyl or, well, they were specifically looking at fentanyl, but they looked at a number of other opioids as well. So they were able to compare that population. So for folks who have opioid use disorder, they could pull out the individuals who had been using fentanyl at baseline to be able to see if there was a difference. And what was suspected is that it's maybe a little more challenging for that cohort. And we did see that reflected in the lower number of negative urine drug results. They were also able to do that formulation comparison. Being able to do some of the head-to-head studies can be really helpful. It was sponsored by the pharmaceutical industry because they were looking at this, but I think there's been a lot of attention paid to extended release, longer acting injections, where that may be an advantage. If somebody gets an injection once a week, once a month, doesn't have to think about it once or twice daily. We've seen that be advantageous for patients in other long-term disease states. So it was nice to be able to at least get some of that comparison. Obviously, it wasn't all of the sublingual formulations, but to be able to get at least some comparative data there. And they had a pretty decent amount of patients be able to complete this. So again, 56% and 61% actually completed the trial. So we still were looking at more than half to two-thirds of patients that, almost two-thirds of patients that did complete all of the phases. It was post hoc, so they had the data and they looked at what could we go back and look at. So it wasn't necessarily set up or designed and powered to see the difference. Although the difference did exist, and it existed in each of the groups that they had looked at between those who had fentanyl present at baseline and those who did not. So no, it was not set up statistically to be powered that way, but that signal was pretty consistent and relatively strong in terms of the absolute difference in the negative urine drug results for all of those cohorts, suggesting that that probably is a difference that we'll see. It also tends to support what a lot of clinical experience and anecdotes have been for those populations. It also was 24 weeks in duration, and I hedged on which side to put this. It was helpful that it was 24 weeks, but it also only was 24 weeks. That last phase where they moved patients back over to the sublingual, it may have been helpful to have open label. And there are some ongoing trials so that hopefully we'll be able to get some additional data to see how things go a little bit more long-term than just those 24 weeks. So from a clinical impact, is it going to be groundbreaking? No, but it really does help support some of the clinical decisions that everyone's making out in practice every single day. So yes, it can still be effective. Buprenorphine seemed to be effective even in those folks who were taking fentanyl at baseline. Although it, and I'm going to drive that home, it really does also suggest that the drugs aren't going to be the only thing that are helpful. They definitely can be a part of it, but they're not going to move all those folks all the way over to recovery. But a quarter of them is nothing to dismiss outright. So it is improvement, but recognizing that from a assistant standpoint, it's likely going to be that we need some additional things other than just having the medications on board. And as we move forward, we might start to see more evidence come out about the differences between formulations. So not just from an ease and adherence perspective, but we may potentially more long-term start to see some differences. And I know that there has been some discussion about, okay, well, what about the transition? So for folks maybe starting on sublingual, how about tracking some of them as they move more to a maintenance standpoint and maybe over to some of those longer acting injections where that they're not having to think about that all of the time, and we can improve some adherence rates in those long-term recovery rates. So more to come on that, but interesting information for a cohort that we don't usually get a chance to look at. So I will stop my share and turn things back over.
Yes, thank you, Sarah. I thought it was an excellent presentation that you did. It was